let's see. Okay. Okay. So let's start. This is a man with approximately 70-gram prostate. He had bothersome symptoms and a PSA of 4, and an MRI was normal. So here we are. You see, he has a rather long prostate. Here, the UO seems to be not so. Sorry, the focus is not very good because we usually try to focus on the fiber. So the orifice is not so close. Let's start. It's been some years now since I published the first video, so let's see how things have evolved. So here, when I come out, I can see the contour of the sphincter. So I'm going to mark here and here. Initially, you see, this keeps me inside, protecting the sphincter. And I'm going to mark the white line going down to the lower limit. And this is going to be a reference for enucleation. Usually, it's very easy to see where is the landmark between the sphincter and the apex, and for me it's a great advantage to have this line already marked that is going to protect the sphincter's mucosa, which is becoming an objective that more and more urologists recognize as an important goal of the operation if we want to keep the best possible urinary continence and avoid urinary stress incontinence. Here we are, early stress incontinence. Okay, so you can see the sphincter is pretty good here. Now we can go, you see there's little space here. I go to the floor of the veru, lateral to the veru here, and I'm going to try to get the fiber to probe a little bit to see where do we access when we come downwards like this, and then a little bit lateral. Let me focus slightly better. So you see this way, usually you can find a plane that is looks like a capsular plane. As you know, with this new modulation of the pulse, in this case I'm using virtual basket at 2 joules and 50 hertz. It gives us a very good hemostasis. So it's very difficult to see the beautiful plane that we used to see when we did mechanical enucleation. So here you can see that I'm doing the same thing. I'm coming lateral to the veru, starting to open this space very carefully, just going up and down, seeing if I can enter a little bit this space that looks capsular. Here we found the limit. This is our white line over here, as you can see. So now I will continue dissecting. If you go a little bit deeper in this situation, you can always correct a little bit the aiming of the laser to try to correct the plane. But as I said, we are no longer seeing a beautiful plane, which is what we would see if we continued dissecting mechanically most of the times, and we are happy to see a capsular plane. And a capsular plane to me is a plane that is a little bit white in color, usually whiter than the color of the adenoma. It is a plane that is relatively smooth. It is a plane that is fibrous, so you don't see cotton-like tissue or, like bread, which could make you suspect that you are inside the adenoma. So we look at the color, we look at the surface. You see it's fibrous in the surface. It's smooth, and also it's coherent, which means that when you go from one side to the other side, more or less you are at the same depth. Often we take planes that are not exactly the beautiful plane, but I would say most of the times when you don't see a beautiful plane, it means that you might be a little bit under it, so deeper than the beautiful plane, which is not a main problem. Sometimes many HoLEP surgeons tell you that instead of an orange, the prostate sometimes behaves like an onion. So having more than one, possible depth of dissection for your enucleation. So here, you see the plane is getting a little bit thin, which is sometimes demonstrating that there is some change in direction of the plane. We're going up to the bladder neck. So usually I develop the posterior plane as much as I can, and while it's still comfortable. You see, I could angle the fiber and continue firing a little bit more upward like that, but then I feel the weight of the adenoma on top of me. And the thing is that we haven't touched the lateral aspect, so it's very heavy. You need to do pressure, and the problem is that you haven't developed the lateral plane enough to allow for some mobility of the apex. So I will stop here. This is enough posterior plane, and then I will turn my fiber to 12 o'clock. Here I have a very nice indication of this 12 o'clock here, as you can see. We can also deepen a little bit the 12 o'clock incision if we want, and that's going to separate us a little bit from the area of the sphincter. So here, as I retrieve my scope, we can see the mucosa, we can see the white line. There's typically some apical bleeding here that I don't think it's even worth it to coagulate. And often I do a little bit more deepening of the white line because I think that gives you much better access and increases the separation of the apex from the sphincter. And then, of course, we want to go and look for this plane. You see, this is the initiation of the lateral plane. Normally I see the prostate, I simplify the prostate thinking it is a little bit boxy. So we have a posterior plane, we have two lateral planes, and then an anterior plane. That to me makes it much more simple. You see that now I'm doing movements going up and down. What I'm trying to do is I'm trying to delineate the lateral line of dissection. The line of dissection will have to connect with the posterior line. And to me, these lines of dissection are like a GPS. You see, I am quite fast with enucleation, and that's not because I do things very fast. It is because I have a reference for navigating the fossa, and this reference is going to help me to be able to work almost continuously. Okay, so here you see lateral plane. It is quite coherent, you see, with the posterior plane. This looks a little bit yellow, so maybe sometimes we can check if we go deeper. Do we find a better plane? Maybe we didn't remove all the adenomatous tissue there. I doubt it because we were already a little bit, deep here, but sometimes it is the color is a good reference that you might be leaving tissue behind. Okay, let's continue with our goal. Our goal is to progress towards the anterior part of the prostate. So here, again, following the white line, I'm going to do now an access incision that goes a little bit horizontally here. You see, I don't mind cutting a little bit on the adenoma because you see what happens is I get a little bit better visibility of where the proper plane is. So I can go after the cuts, there is some space, and I can look for the proper plane and then try to continue my dissection. I don't want to go all the way to 12 o'clock yet because I haven't, let's say, developed the lateral and anterior. So the upper part of the lateral plane here, you see, I can go a little bit further up. Let's see. You see, and also there's another concept that is I am lately recognizing, and people, when they watch these procedures for the first time, they think that I'm guiding myself exclusively by what I'm seeing on the screen. And the truth is, if I stop at any moment, for example now, it's not very clear in this image what is capsule and what is adenoma. You see, of course, if we have memory, we can remember a number of photograms. You see, we can remember that we are drawing a line, the lateral line, that I am following up. But of course, when we're coming up, I am on the right side of the patient here coming up. Of course, we know that the line has to go towards the right, towards our right, or towards the patient's left. And how do we know that? Well, we know that because we know prostate anatomy. We see a lot of MRIs from patients of all different kinds, and I always look at the transverse sections because I like to see how is the shape of the adenoma. And basically what I'm trying to say is that often I don't guide myself exclusively from the information I see on the screen, but I also guide myself based on the knowledge I have of prostatic anatomy and the shape of the adenoma. So basically I tell people who come to watch the operations, I tell them, you look inside the image, but I look outside the image. So if you think about the screen that I'm looking, you're only seeing the circle and of course there is a screen. I try to look and imagine how the prostate looks like outside of this image, and I try to draw the lines, you know, that delineate the interface between adenoma and capsule, because this, let's say, general view allow me to anticipate how the line is going to look like. And then, of course, the information on the screen is going to tell me if I am right or wrong, you know. For example, if I see that I'm going very deep on the capsule or penetrating the capsule, of course I will have to correct. But also sometimes the image in the screen confirms my suspicion. You know, I think the plane is going this way, the line that I'm drawing, you see with my fiber, is going this way, and this is how I think anatomy should go in this patient. So I base my lines and the way I dissect more on this concept, developing the lines, coming around, and now starting the anterior dissection. You see, when we detach the apex from the anterior parts, the apex descends, and then we have a much better access to the 12 o'clock tissue. This is 12 o'clock, you see, it's a little bit rotated now. So let's come out, check again. You see sphincter's mucosa, so I will come here and I will make an incision. I don't mind if it is, I want to deepen the white line, you see, and it gives me a little bit better access. So I can start the lateral line on this side. Also up and down movements, more or less, trying to connect the lateral line with the posterior line. I call this phase the mobilization and connection phase, because I'm starting to mobilize the apex posteriorly and laterally, and also I want my line to connect to the line of dissection that we had before, you know, on the posterior plane. Here you see there was a doubt, is this the proper depth? Maybe we can go slightly deeper. We can always explore these doubts, you see, when you have reasonable doubts because of the color or the consistency of the tissue. For example, here you might want to go a little bit out. You see, when we go out, we see thin capsules, so probably we decide to stay in the same place. So up and down, lateral plane, lateral line, and connection to the posterior line, trying to get a uniform line that we can recognize easily. So if I had to give the operation to another colleague, for example, he would perfectly recognize the landmarks of the operation, because I'm drawing with my fiber a circumferential line that is going around the adenoma, and it's following these depths that we found, the capsular plane depth. Another factor in the definition of the capsular plane, I said it is wide, it is smooth, it is fibrous, and I say it's not perforated, okay? This plane looks slightly, you know, we are starting to perforate, and of course we need to stop before the perforation is established completely, you know? So I used to say that little perforations are allowed, but of course you don't want these little perforations to become very big, very large perforations. Here I am coming towards the apex. I don't want to continue dissecting upwards here, forcing the situation, because I'm going to make a little bit of traction here near the sphincter. So here I'm doing my white line, deepening line, access line. Again, I don't mind cutting a little bit of this apical adenoma. Here, of course, I'm going almost horizontal because the sphincter is above us. And then I'm going to look to continue my lateral line. Here suddenly we see a little bit worse. I saw a beautiful idea from Figueiredo from Brazil. He did improve his mini-LEP cystoscope with little holes for drainage of water in the tip of the endoscope. So when you are working in, sorry, that's the sphincter came out. When you're working in the very restricted spaces like this, you get better outflow, and that better outflow is going to improve the irrigation, because you will have the ability of putting water inside, and wash, which is what you want. Here you see when the outflow is a little bit compromised because the orifices of the endoscope are compressed by the sphincter and by the prostate and like that, the drainage of the endoscope is not so good, and then you don't see so well. So congratulations to Felipe for this. Here we are, you see, now I'm connecting anteriorly, so this is the end of the early apical release. I really didn't do much at 12 o'clock, but I think the fact that we descended the anterior part quite well, probably in both sides, made it very easy to connect anteriorly, and now the apical release is finished. We know that the mucosa of the sphincter is okay. You see, you don't see my hands, but I'm holding the scope with my fingertips. I do very, very gentle movements with my scope, and I think if you need to do a lot of force in this operation, it's not a good idea. So you never use force. I have seen people bending the endoscopes during HoLEP and even breaking the optics, and I think that's a mistake. You need to work strategically so that you can start accessing different spaces, and you get better access by gaining mobilization strategically. For example, here we want to go anteriorly. You see that the shape of the plane is going down now, and in order to go down I have to push the adenoma a little bit downwards. But if I have the adenoma hanging from here, you see, laterally, it's going to be difficult to bring it down. There will be no mobility, so I have to come a little bit lateral and try to detach these lateral attachments in order to have a good mobility, so that I can lower the adenoma. I can crush it a little bit, or squash it a little bit downwards very gently with the tip of my scope to be able to come near the bladder neck. Also remember, you should be able to have a technique, and you should develop your skills so that you can continuously work. You see, I move very slowly. I work mostly all the time. I do very brief pauses on my lacing because I have a good orientation. I have a good understanding. This is my lateral line. Sometimes when you develop the anterior space, if you don't go downwards laterally and you don't connect with the previous line, you can have these little, let's say, discrepancies, that you have to solve as soon as possible. And remember that we advance the operation by looking after these lines, because this is our reference, this is our guidance, you see. And you see, I don't need to stop too often to look back, to get oriented. I know exactly where I am. I'm trying to think how this line should go, and I draw it as if my fiber was a pencil, And then, of course, the fiber and the pencil have a lot of similarities. With a pencil, if you have a 2B pencil, for example, you can draw, that's the bladder neck. You can see the vertical fibers below the circular fibers in this side. So here we are reaching the bladder neck. now at this stage I'm going to puncture to equalize the pressure on both sides. And I don't want this mucosa to balanize, you know, to push with the pressure of the water so that it dissects from the anterior wall of the bladder. As you know, here many times we have bleeders in the mucosa. You know that holmium cuts by disruption. So often there will be small bleeders in the mucosa, and now it's a good moment to go up there, because as we are pushing the adenoma downwards, the bladder neck is coming down, so it's very easy to access here. You see, so typically I would spend a little bit of time trying to ensure that all this incision in the bladder has been coagulated. Now I'm using the magneto setting. You know, the magneto is a tweak of the holmium laser to emit longer pulses, and these longer pulses improve a little bit the hemostatic properties of this laser. I think it makes it more similar to what we get with a thulium pulse laser or a thulium fiber laser. So I welcome very much this new ability of the laser to coagulate. You see, with an effect that looks a little bit more like, you can even see a little bit of charring on the tissue, which is quite typical of thulium lasers. So it's a good moment to stop for 1 minute and do a little bit of hemostasis that otherwise you have to do later, and then we can continue. You see, we have already released most of the prostate here. We can go in and have a look at the UO. We saw it before, quite far away. There it is. So we are not worried about the UO. And now my next objective, as you can see, is to release the lateral attachments near the bladder neck. So I'm going to come here, come downwards, come up again. You see, some people, when you see them operating, they do just one go with the laser. They stop, they go back, they check, and then they do another one. You see, but this is using probably twice as much time as if you achieve, let's say, a technique that allows you to work almost continuously. So that's my advice. Work very slowly and train your skill when you do your cases. Try to have longer periods of lasing, so that you can avoid stopping all the time, which is going to consume the operative time. So the slower you go, the faster you progress, let's say. And here I'm seeing the plane is a little bit deep, let's say, so I'm going to target my fiber a little bit closer to the adenomatous tissue. You see that when I target close to the adenoma, most of the energy remains in the side of the adenoma, and I don't deposit so much energy near the capsule, which is good to try to avoid causing a perforation. Typically, I mean, you could continue posteriorly. Here, I'm going to do a little bit. I'm going to come posteriorly to see how my lines, the posterior line and the lateral line, can connect. Of course, look at my fiber. I'm firing up very, very close to the adenoma because I don't want to deepen in the capsule. If I fired, you think the line of dissection is here. If I fire here, maybe I will perforate. So I need to go up there to continue dissecting posteriorly with some degree of safety. Sometimes the capsule in this area is very, very thin. Here, for example, we entered, I think, a seminal vesicle. We are so close, or how do you say, the deferential ampulla. Sometimes we see these things. So I know that I have to go further up and remain that in place. I haven't seen that causes any postoperative trouble. No, it's not a complaint. I have to say that I see, very often I see ejaculatory ducts, I see these openings of the ejaculatory ampulla or seminal vesicles even sometimes. And I don't see, it's very, very rare to have a patient complaining about, let's say, symptoms related to that. We don't see also many postoperative infections, although I send the patients home with a prophylactic antibiotic for a week after the operation. Just try to prevent these events. No, here, posterior line. This is my lateral line on this side. Let's see how bladder neck is looking over here. You see here, we have to do more work than in the other side. So I'm going to try to draw my line. You see, I'm drawing my line. I'm trying to connect the line I did before with the line I'm doing now. You see, try to keep long movements. I don't like to do very short movements of the scope like this. For example, if you do like this, you're going to get deeper just in one spot, and then you will have a very irregular line. So I'd rather do long lines. And you see the way I try to use the energy. So I choose working distance that gives me a very soft effect, because if you have a soft effect on your line, if you avoid contacting the tissue, as Cesare Scofone suggested, no, the no-touch technique, I think it's very nice, because you are developing the plane slowly and safely, because the energy you are using is incapable of perforating, you know what I mean? So even if you start a perforation, you're going to be able to see that a perforation is starting, and then you will have a possibility to correct your aiming, get closer to the prostate to prevent enlarging the perforation. You see, so it's minimal improvements in your dissection, in your strategy, in your lines. You see, this is posterior line here. Now I'm going to transition probably towards the lateral line. Let's see how it goes. Here's posterior again, coming towards the other side. Here I am almost connecting to the other side, but I will continue. You see, you have to very subtly, very carefully, change your aiming so that you can progress with successive passes, you see, of the laser. That is going to give you also a very good hemostasis. So you can progress, let's say, worried on the technique and not so much on keeping a good hemostasis. Here we could check, maybe that looks a little bit yellow. Maybe I could go even slightly deeper here around the corner here. Remove that little tissue there. And you see, even when I correct my line, I try to devote a little bit of time to create another deeper line that I can perfectly identify and see, and then I'm connecting this line to the posterior line we were following here, and then I'm climbing up slowly. Here you can see some signs of deep depth, let's say, of the dissection. So, but this is how we slowly decide which plane we're going to follow. That's the idea. Here, for example, there's almost a little bit of fat, so we need to get slightly closer to the adenoma. You see, this kind of deepening is really significant if you are able, of course, to correct. You see, to correct a little bit your aiming. Sometimes the prostate is a little bit sticky in some areas. It's not detaching beautifully. It's more difficult. So we get, you are patient. You try to improve, and if you see that you are in a place where you cannot progress very well, don't stay too long, because I think often when you cannot have access in one point, you cannot get much improvement. The problem is a problem of mobility of the adenoma. So you go somewhere else, you try to advance the operation somewhere else, even in a remote place, even you go to the other side, and then you continue detaching, and then the general mobility of the adenoma is going to improve, and voila, you see, when you approach again this area where you had very much difficulty to release this corner, for example, then you see that there's much better mobility, it's much better access, and then here we still have a little trouble, but it has improved significantly, and now we can see the other side. You see, this corner now, it's totally released. If you think of the shape of the prostate, this angle is usually the most acute angle that we have to negotiate around the adenoma. And again, this is posterior plane. See where I'm firing? I'm firing very close to the edge of the adenoma, so that we don't deepen in the capsule. Here, I'm doing my wide movements to connect one side with the other side if I can, and progress. Again, when you're doing the posterior phase, the posterior plane here, basically you do movements from side to side, but when you're going to change direction, basically always you have to go a little bit further up. So when I'm going now to the right, you see I come to this side, then I go up again, you see, because we want to follow the prostate. Now the prostate mobility is increasing a lot. You see that I can lift it a little bit without any difficulty. That's giving me progressively better and better access in the posterior side. Okay, so here, let's have a look. Here, often we can lift the adenoma, put it on top of the bladder neck like I did now, and if you give a little gentle push, you see the prostate has rotated now, and that is going to open up for us, you see, all this space that was a little bit more difficult to access, and now I can continue. You see, this looks a little bit yellow. This looks deep, let's say, so maybe it's not a worry. I don't think that's a lot of tissue there, but still, you can always investigate. You can always investigate and see if there was more tissue to take out, or you can even use the laser to vaporize little, remaining pieces of tissue. I think that's deep enough. I think I don't want to overdo it, but sometimes, when you see a little bit yellow tissue, you investigate below it, and then you find a nodule. You see this little tissue. This is nothing. Also, this is nothing. Sometimes the capsule itself, the peripheral zone, can look a little bit yellow. Here we are coming up and down, trying to see if we can release this posterior plane now coming. Let's see if we can connect this to the bladder neck region here, up here, you see? This is bladder neck. Now I'm coming down and around, coming through. Here we are, you see? That's, sometimes the recognition of the plane is difficult. I don't think there are two cases where you can say the plane looked exactly the same as the previous case or something like that. You will see a lot of different aspects of the plane. But as I said, if the plane looks smooth, more or less uniform, maybe in some areas we got a little bit deeper, but we were able to correct our, you see, path. No, we correct our path. This is a little bit of hemostasis with magneto here. So we are okay. This is now bladder neck here. See, the UO was quite far, so I'm not, let's say, especially worried about hitting the UO when I come here. In this case, otherwise I would look inside. Still, the bladder neck looks a little bit high, so I'm going to lower it here, cut it down, following the curvature of the bladder neck fibers. You see these fibers? You try to follow the curvature, and now if we go in, we can see the UO. It's not too far. It's not too far, but it's not too close. You see that we push the prostate almost completely now. It has gone on its own. And then for the 6 o'clock final detachment, sometimes I prefer to have the fiber at 6 o'clock. And then this line is like drawing a smile. You see, going from one side to the other side, trying to find, you see, the connection and trying to release the last attachment at 6 o'clock. So I find that enucleation has a lot of similarities with drawing and throwing these lines, being able to draw these long lines that go from one side to the other, and also the same way the artist has his painting in his mind, and then he draws it on the canvas or the paper or whatever. We also have an idea of how the anatomy of the prostate looks like, and then we guide our movements. We guide our movements to be able to draw these lines. There we are. To me, personally, I think the pulse modulation we had with Moses and with virtual basket changes things. Maybe when you look at the data, and is there a significant difference for patients? That is maybe questionable. I don't know. Maybe, I mean, someone is very, very good with his classic 100 watts holmium laser, and they do a very, very good job. And they don't notice a lot of difference in the post-operative. But I have to say that the quality of hemostasis, the quality of the first pass hemostasis, subjectively improved a lot for me. And you know, occasionally we still have the classic 100 watts, and sometimes we work in 2 operative rooms, and sometimes we, for a practical reason, we don't want to move, you know, from one operating room to the next with the laser and change it all the time. So we have several lasers here. Sometimes I do thulium fiber cases. Sometimes I do classic holmium cases, you know, and now this is the magneto setting. The UO is over here. So as I said, it is an advantage when I have to tackle, you know, a very large gland or a very difficult case. I'm always much more happy if I have the virtual basket with me. And now, of course, the magneto. Sometimes especially when you follow this technique, but I see people operating maybe not so aggressively down the capsule, maybe trying to follow a much more conservative route. You know, sometimes even I recognize nodules that are attached to the prostatic fossa that they're going to leave behind, and I would never do that. And of course, this aggressiveness has, let's say, this possibility of getting a little bit deeper where we can find some vessels. And to me, having the magneto is a great, also welcome. Of course, this is very subjective. Maybe, I don't know if it will influence the postoperative results, but since we use it, I think we have observed that we have less patients having acute retention after removing the catheter after the operation. So maybe there is some clinical advantage. We will have to see. Subjectively, I think pulse modulation has been a great advancement, and this is my personal opinion. And you know that expert opinion is probably the lowest form of clinical evidence. You can see that we did a nice clearance of the tissue relatively fast. I didn't do anything abrupt, anything, you know, very, very aggressive, and remove the catheter of this patient tomorrow morning, despite having seen a little bit of deeper planes or deeper areas where you can see sometimes an injury fat. And if we come out, you see the verumontanum, you see the sphincter, you see that the preservation of the sphincter has been extremely good. You see, this is the landmark that I marked, and this patient, I'm sure, that will be perfectly continent. Sometimes patients can tell you that they have a little bit of urge incontinence. Sometimes, of course, the hyperactive bladders sometimes do that to the patient. But he will not tell you, I have stress, incontinence, and of course, most of our patients are dry very, very fast, and we're very happy to respect both UOs. Now I'm going to do the final check on hemostasis. And you see, now that I don't have the adenoma in the fossa, if I try to reach the bladder neck, sometimes it gets a little bit more difficult, you know, reaching out up there. In this case, not so much, but in bigger prostates, often we find these difficulties. So there we are. Now I think we're ready to start the morcellation. There we are. That's the piece. Still attached by a little this one. One thing you can do if you want is to do little cuts on the adenoma. Try to make the surface of the adenoma more irregular. Some people do that. And I think if you see that the plane is very smooth and there's not a lot of irregular places where the morcellation can probably comfortably grasp the prostate, you can do this to make it even more irregular when you do the morcellation. Let's change. So it's been a while, I think. I'm very happy to see that there's a lot of people contacting me to say how useful the videos were to them. And I'm very happy to see that many people, when they teach others and when they do their own videos, they use concepts that probably heard from me here in these videos. And I'm happy to see that all these ideas and all this useful knowledge is being used by people. Here I have my wonderful nurses. They are always helping me so well that they allow me to have very fast changes of instruments. See, when we start the morcellation, often the tubing is full of air, so the initial behavior of the morcellator is not so good, and then it starts to grasp the tissue a little bit better. Sometimes it's because you need to prime the tubing with water. If I don't get very good, let's say, morcellation, I try to do the upside down morcellation. This is something I do more and more. You know that the Japanese and the Asian urologists like this approach much better, much more than in Europe, I think. But the idea is quite sound and quite nice. You see, the prostate or the adenoma is between the mouth of the morcellator and the bladder wall. It's quite safe. Also, the adenoma tends to float up. So basically, you're weighting it from the upper part. And you see, I change to see what kind of positioning of the endoscope will help me. Often, after a little bit of upside down morcellation, you can then go back to a more comfortable for me, because I have done thousands of hours of morcellation this way. But it's an alternative, and I think it's a nice alternative to play with, a nice resource, because sometimes, as you know, the BPH tissue could be quite hard and difficult to morcellate, and then every trick that we can pull out to aid with morcellation can help. So here we are now on a cruising speed. No, it's more normal morcellation. You can tell the tissue is a little bit hard, not so flexible, not so nice. You know that morcellation relies completely on suction. I'm going to turn off. Oh no, I can't. With this handle, I can't turn off the suction. But if you turn off the suction, you can see how the morcellator rotates with no effect on the tissue. My feeling is that the bladder is not so full, so I'm going to wait a little. As many of you know, I only use one inflow of water. So often, if the morcellation is not efficient, the moments when the morcellator is not attached to the tissue, I could be sucking a little bit of water out, and then this will empty the bladder. The problem with emptying the bladder is that the pressure drops, and then some of the bleeders that you didn't see when you were checking if the hemostasis was good before morcellation start to bleed a little bit, because the pressure has dropped very fast. And if you think about bladder physiology and bladder urodynamics, you know that the bladder initially fills without much increase in pressure. It is at the end of filling when the pressure goes up. And of course, when we have a distended bladder, probably there is quite a high pressure in the bladder, but the moment you start sucking a little bit of water out, probably the pressure drops significantly. So that could explain why sometimes during morcellation, especially when morcellation is inefficient, that you have all these moments where you're sucking water out. You see, you have to stop because you don't want to suck all the water out. You wonder, the morcellation is difficult because the tissue is harder, and also the visibility is not so good. So basically, what I do is I wait a little to fill the bladder up. Although sometimes, even if I see that I have a big piece and I have to morcellate, and I see that the morcellation is not so good, I might ask for second line to get another couple of bags and to get more inflow, maximum inflow that I can get. Try to compensate for this. You see water coming out. Huh? Okay. Also, often you see HoLEPs performed by people who are a little bit more conservative than I am, and they probably get better hemostasis. Maybe podemos subir los suelos un poquito. Maybe we can lift the pressure a little bit high. Venga, subirlos un poco de altura, because the bags, as they empty, vale, inside. As the bags empty, the pressure that you get is lower, because these bags measure like 25 centimeters, and if the bag is full, the level of the water is much higher and the pressure in the bladder is much higher. And then when the bags are getting empty, the level of the water goes down, so the pressure goes down. So there we are, trying to morcellate. Vamos a cambiar por favor la boca, a ver si se puede reducir. I'm going to ask my nurses to help me with the size of the mouth. You see, sometimes if it's too open, ¿quién lo está haciendo? Okay, that's perfect. You see, if you put them halfway, see the quality of the suction improves. And often that means that even when the tissue is harder, you're going to get better morcellation. So one of the nice aspects of this morcellator, the piranha system, is that you can tailor the opening. If the opening is very small, the flow of the suction at the opening is much faster, of course, and then the tissue or the suction is much stronger, so you get a little bit better attachment, and probably that was one of the problems. We were trying to morcellate with a wide open mouth, and then the suction is less. Maybe that's good enough for softer adenomas, but not so good for a little bit harder or more fibrous adenomas like this one. The thing is, we cannot predict which adenomas are going to be easier to morcellate and which ones are going to be difficult. You never know. And I don't think there's a clear correlation with having drugs before, having biopsies before, or having chronic prostatitis before. I doubt there is any. I think there's so much variability that also if we predicted it, what would we do? We have to struggle with the morcellation anyway. So there we are. That's now getting better. Also, I have to say, the sucking a small piece is much easier than sucking a big piece, because if the piece has a big mass, there is a lot of inertia. Maybe they might cable. So when the piece gets smaller, it's usually easier to lure them into the morcellation mouth. And here we are. This is the end of the enucleation. You can see a little bit of blood coming down by gravity. This is the sphincter, and we finished. Thank you very much for your attention. Muchas gracias. Estupendo.